Hi, everybody. I'm Parvati. I'm one of the sleep providers at Yale. Thanks for coming to the Yale Sleep Medicine Grand Rounds. Just to start, we'll do a few brief housekeeping announcements. First, please take a moment to ensure that you are muted. Please see instructions in the chat to receive CME credit for attendance and a one-time sign up for a Yale CME profile to receive credit. If you think anyone else would be interested in joining us, please email yalesleepmedicine.grandrounds@yale.edu. I will be moderating the session. If you have questions or comments during the presentation, please use the chat or at the end of the talk, take the opportunity to unmute yourself to ask your questions. Recorded versions of these lectures will be available on YouTube a few weeks after the presentation. Now to today's speaker, I have the pleasure of introducing Dr. Andrey Zinchuk. Dr. Zinchuk received his medical degree from the University of Connecticut School of Medicine. He completed his internal medicine residency at Beth Israel Deaconess Medical Center and his pulmonary critical care and sleep medicine fellowships at the Yale School of Medicine. He is an associate professor of medicine at the Yale School. He is an associate professor of medicine at Yale. At Yale, he serves as the director of the Advanced Apnea Management Program and the Yale Upper Airway Stimulation Program. In addition to his clinical work, he is a prolific researcher and has been the recipient of several grants, including from the NIH. His research primarily focuses on identifying obstructive sleep apnea phenotypes based on physiology, prognosis, and treatment responsiveness, as well as developing novel treatment options. In recognition of these contributions, he has received the American Thoracic Society's James B. Scrutrude New Investigator Award in 2024. Beyond his research and clinical work, Dr. Zinchuk is deeply committed to international service. He is the co-founding director and vice president of Doctors United for Ukraine, a nonprofit organization whose mission is to deliver aid and support the health of the Ukrainian people, with a particular focus on critical care, mental health, and women's health. Thank you for being with us, Dr. Zinchuk. And without further delay, I would like to hand it over to you so you can share your expertise on OSA phenotypes.
Thank you, Dr. Singh, for this nice introduction. It's nice to see you. Nice to see everybody here at the Yale Centers for Sleep Medicine Grand Rounds. I am very excited um, to share some of the work that we've been doing and also look forward to chatting with you about this work and getting your input on it. And so we'll get started. What I would also say is that, please feel free to add your questions into the chat, and I myself and Parvati will be able to review them. And so nice to see everybody. My name, as you've heard, is Andrey Zinchuk, and I'll be talking to you about understanding heterogeneity and sleep apnea treatment response today. And this is the disclosure slide. I do finally get some consulting fees from ApneaMed and have grant funding from ResMed for the work that we're doing. But none of that is related to the things I'm going to talk about today. And so if you wanted to get credit for CME credit for today, you can just text 53863 to the CME number at Yale to get your credit. And so the overview of today's talk is going to have to do with a little bit of introduction about the heterogeneity of sleep apnea, and specifically how treatment responses may differ among different people. And then we'll take a little bit of a journey to understand some physiological OSA traits, which I think most people have been familiar with. But I'll talk a little bit about how they're actually measured and some of the variability that's inherent in that measurement, and also how these traits might then manifest as phenotypes. We'll spend a little bit of time talking about how these traits may actually be associated with differential outcomes of CPAP therapy, of OSA therapy. And briefly spend a minute or two talking about, what integration of these traits might look like in the future for sleep apnea care. And then I'm going to take a bit of a left turn and talk a little bit about a risk factor for cardiovascular disease in sleep that we had come across during our work in trying to look at sleep apnea phenotypes and cardiovascular risk that we did not anticipate finding at the beginning. And so the reason why I do this work is illustrated here. These are all the people that have been wonderful mentors, research colleagues, and collaborators in the work that I do. And I love this part of my job, is interacting with these humans who are curious, fun, brilliant, and just great to work with. And so I just wanted to share with you, and you see some familiar faces in Clara Yagi, and then this is Dr. Sands, who has been my mentor in physiology research and really has helped me understand a lot about sleep apnea and why it occurs. And we have our research team, Naya, Yuri, Mohammed, and Munib that have worked with us in the past year, former fellows who are now faculty at various places, and our colleagues, Allison from cardiovascular division, Dr. Ku from neurology, Melissa Knauert, who does circadian research, and Yüksel Pecker from um, Turkey and Sweden, with whom we do cardiovascular work. And so I just wanted to say that this is the reason why we do this work, and it's so exciting. And let's get on to the main part of the talk. And so I just want to introduce a couple of individual cases that I saw that inspired me to do the work that I do, that really highlight the differences in how people are able to use or not use CPAP and how it affects them. And so the first one was my first patient in the VA as an attending physician uh, in Boston, in the Boston Clinical VA. It was an ex-Marine. He's 56 years old. He was obese with a BMI 42, had hypertension, diabetes, and had a diagnosis of chronic diaphoresis in his CPRS. And when I was talking to him, I started, saying, "Oh, I'm probably sleeping about 3 hours per night. I wake up a lot." And he came to see me for something totally different. He came to see me because he had earache. But we spent a little bit of time talking about like why he's miserable at night and can't sleep. And it turns out that he's had a diagnosis of sleep apnea that was, done like a couple of years ago, but he never followed up on it. He had an HI of 36 and, has pretty deep desaturations. And so, I said, "Hey, I'll give you some drops for your ears and also prescribe CPAP for you. So if you can do that, you might sleep a little bit better." And so, he came back a month later for follow-up and, he's just loved it. He's like, "Doc, that CPAP saved my life. I loved it." And really, he was able to sleep for 5 or 6 hours uninterrupted, which is a huge change for him. And really just sort of, took off from that point on in terms of his sleep. And then, when I first started here as a fellow, I saw this 58-year-old woman who was an executive. She was a little bit different. She had a BMI of 28. She also had hypertension, diabetes, anxiety, and depression. And similarly, she couldn't sleep at night. She had very disturbed sleep, can't stay asleep, had similar severity of sleep apnea, but a little bit of a different oxygenation pattern. Her nadir was much, much higher. But she really struggled with it. She tried CPAP multiple times, had come back and forth for mask fittings, and just even when she wore it, she felt like she was just not benefiting from it. And so these are just two examples that really drove to me that, gosh, sleep apnea is not the same thing, and the treatments are, responded to so differently among people. And so why is that, and how can we, leverage that? And so this is a graph from a recent study that was published in Thorax from a group in the UK, and they're just showing, a reflection of what we see in our clinical practice. So they took about 1,000 people who from 5 different sleep centers in the UK and monitored their sleep usage every night. And what they saw that there are actually very different trajectories that get set pretty early in the course of CPAP use for all those individuals. And so, there's about a 25% of people start well and stay well. And so that's, this green line. But then there's about 20% of people who like can't do it. And they just, no matter when they start, when they use it, they just can't handle it. And then there's actually a bunch of people who change their trajectories. And so one of the things we're trying to understand is, why is that? And in addition to established psychological and social factors like social support or readiness for change, what are some of the other reasons? Are there some perhaps biological reasons why people can't deal with CPAP or love to deal with CPAP? And, one of the things I want to point out is that this is real world recent data. And, over here, it shows you that this black line is 4 hours per night. And so, gosh, almost 65% of individuals, can't use CPAP for longer than 4 hours a night. And so that's been actually one of the reasons why people have thought that, the large randomized clinical trials of CPAP therapy in cardiovascular disease or neurocognition have been largely negative. They show that CPAP doesn't really improve risk of cardiovascular disease or neurocognition in people who have established sleep apnea or established cardiovascular disease. And so these are just some of the studies that have looked at these. And so why might that be? And so, certainly could be that the dose of CPAP is insufficient. But it could also be is because in some people, sleep apnea may not lead to cardiovascular disease as opposed to others. And so this is a study that was published in 2022 in the Blue Journal that looked at a real world cohort of about 5,000 people in France. And what they did is they measured hypoxic burden in these individuals from their diagnostic PSGs. And what they saw, similar to other folks who have looked at hypoxic burden, is that, depending on how deep and long your desaturations are, so if you have long, deep desaturations, you're much more likely to be at risk of major cardiovascular events. And so this is this hypoxic burden of 71 or more. And so, there's physiologic heterogeneity, that impacts risk. Then there's may also be heterogeneity in terms of treatment response. And so Ali Azerbaijan from Brigham and Women's Hospital and I had collaborated along with a whole large group of people collaborating in conducting essentially a individual patient-based meta-analysis of these randomized clinical trials of CPAP therapy in people with cardiovascular disease. So, SAVE, Isaac, and RICADSA, and that's about 3,600 patients. And based on preliminary data that Ali had developed, is that people with high hypoxic burden, so more than 87% per minute per hour, or a high heart rate response to an apnea or hypopnea. So if you have an apnea and your heart rate goes up by about 9 or more, that is supposedly portends higher risk. If you classify these people into different risk categories, does that help you understand whether they respond to CPAP or not? And so among all these trials, if you lump all these people together, what you'll see is that CPAP and usual care make no difference. But then when you look at the high risk OSA, which are those individuals with high hypoxic burden or heart rate response versus those with low, then you can start to see big differences. And so your MACE-free survival actually is improved with CPAP in individual in the high risk group, whereas in the low risk group, this turns out to be not significantly different, but it seems like there may be almost a signal for harm. And even if you look at people without excessive sleepiness, which is majority of people in this cohort, is that you actually might be getting a little bit of a signal for harm in people with low risk OSA with CPAP. So CPAP may not be the right treatment for all, and the response differs. And so, this kind of data has really been the supporting evidence for our hypothesis that we had, back in, 2017, 2018, that really sleep apnea's heterogeneity can influence the risk of cardiovascular disease, adherence, therapeutic efficacy, and treatment effectiveness. And this heterogeneity can come from multiple sources. It could be the phenotype, or it could be the pathogenesis of sleep apnea. So like how and why sleep apnea happens that may lead to this. And so for the rest of today's talk, what I'm going to do is talk a little bit on the more proximal causes of sleep apnea rather than necessarily the phenotypes of how that may influence adherence, therapeutic efficacy, or treatment effectiveness of CPAP. And so let's talk a little bit about these physiological traits, and I'm sure many of you are quite familiar with them, but this may be a nice review and some new information for some of you. And so Dr. Chu from our division had done a very nice job sort of pulling together a bunch of data to try to understand and write a review on how sleep apnea happens and what might be the influence of these different traits. And so, based on theories from Bob Owens and Atul Malhotra and a bunch of other folks who preceded them, the major determinant of sleep apnea is anatomical compromise. So it's the fatty deposition in the soft tissues, it's the musculoskeletal structure that influences how open or narrow airway is. And if those anatomic features are protective from sleep apnea, so you have a wide airway, you don't have obesity that precludes you from really having sleep apnea. So, no matter what happens, those people are the ones that are protected from sleep apnea. On the other hand, if people are at very high risk of sleep apnea due to the anatomic collapse, either from the soft tissue deposition or the positioning of those soft tissues or from small skeletal structures, you're going to have sleep apnea no matter what. But it turns out that there are a lot of people, in fact, somewhere between 30 to 65%, who have this thing called vulnerable airway that doesn't go to either extreme. And so those individuals may actually develop or be protected from sleep apnea based on these physiological determinants of sleep apnea. So loop gain, muscle responsiveness, or arousal threshold. We call them traits. And some others have called them endotypes. And so let's talk a little bit about how they might actually lead to sleep apnea. But before we do that, we should actually talk a little bit about how they're measured. And so the way that they're classically measured and the gold standard for measuring them is to really challenge the sleep apnea, challenge the patient system, and see how it responds. And basically, like you poke the bear, and essentially the way you do that is you take a person with sleep apnea, you titrate them to optimal CPAP pressure, and then you slowly drop that pressure and see how the system responds. And so, that can be kind of brutal, but that's what people have done in like real hardcore physiological studies where individuals were instrumented with epiglottic catheters and EMG electrodes to measure their muscle responsiveness. And so let's talk a little bit about how these different traits can lead to sleep apnea. And so what you see here on this graph is a plot of these different CPAP drops. So each circle represents data from a CPAP drop. Uh, and on the y-axis, you have muscle activity of genioglossus, the tongue muscle. And on the x-axis, you have something called ventilatory drive, or really the pressure that is measured by the epiglottic catheter, right? So it tells you how much the body wants to breathe. And so you see these two very different responses. You have one person who has a good response. So, the higher the ventilatory drive, the more the muscles are activated, and the more likely the person is going to maintain their patency of the airway. But this other person has like zero, nothing's happening. No matter how obstructed the airway is, no matter what the ventilatory drive is, their muscles are not responding. So, it's no surprise that this sort of physiologic phenotype would lead to sleep apnea. This other physiologic phenotype that or endotype people have talked about is something called loop gain, which essentially is a measure of how sensitive a breathing system is to a disturbance. And so what you see here is a plot of a person with somebody who has a relatively normal loop gain. And so on the y-axis is flow, and the x-axis is time. And you see this person is breathing in and out and titrated nicely on CPAP. And then what you can do is you can drop the CPAP level and the person develops a hypopnea. So that's your ventilatory disturbance. And so the body tries to adjust and increases his ventilation, but only can do it to a limited time because they still have obstructed airway because of the CPAP being lower. And that's the CPAP induced breathing disturbance. Then what you can do is you can dial the CPAP back up to the therapeutic level from, let's say, 5 to 10, and the body then responds. And the degree of that response is what allows us to measure this loop gain. So essentially, we take the response divided by the disturbance and tell us how the sensitive system is. And so this person has sort of a normal sensitivity where the breathing increases and then eventually sort of stabilizes. Now, this person is quite different, as you can see. And so what happens in this case, that response is exaggerated. It's actually 4 to 5 times of what the disturbance is or more. And eventually the person, because they hyperventilate, they'll get an apnea due to this hyperventilation. So they'll have the excessive reduction of PCO2, then the drive goes down, and the drive goes down, the upper airway muscle goes down, and then leads to a blocked airway. And so some individuals just sort of cycle through this process, and that's what causes them to have sleep apnea. And then this last physiologic trait or endotype that people have been referring to as potentially causative in sleep apnea is arousal threshold. And arousals have sort of had this dual role in sleep apnea. And the primary role that we are familiar with, that I was familiar with when I was learning about sleep apnea when I was in medical school and resident, was that they're really protective, right? So like if we have obstructive breathing, our airway closes, PCO2 rises, PO2 goes down, try to breathe, we can't. And if we can't breathe, then the body says, all right, let's wake up. So the body wakes up, the ventricular drive increases, upper motor neurons are recruited, upper airway opens, airflow resumes, and off you go. And so that's protective, especially for people who have OHS. But then there's this sort of other side of arousal that can actually destabilize breathing. And so especially in those individuals who may have fairly mildly collapsible airways, easy arousability or arousals can promote impaired sleep continuity. And so you don't get as deep a sleep, you don't get as stable sleep. So when you awaken, you have larger reductions of PCO2 with your recovery breaths, which decreases the drive to the muscles, and then you can cycle through that process, leading to recurrent sleep apnea events. All right. And so and these are really nice concepts. And conceptually, when I was learning about them, they seem to make a lot of sense. And I was like, okay, let's measure them. How can we do that? And well, we most people don't have equipment to do this unless you're a very specialized physiology laboratory. And most patients don't want to have an epiglottic catheter and they don't want to have an EMG needle in their mouth to do this. And so if we're really going to study whether these traits are relevant in clinical populations, we have to have a way to do it. And so this is Scott Sands from the Brigham and originally from Australia, who actually came up with a brilliant method to measure these traits from a routine clinical PSG. And so, what he does and what we do is we take the data from a PSG, we export it into EDF file, European data format file, and then we can actually look at each signal. And it turns out what Scott has thought of is that each apnea or hypopnea, so we don't need a CPAP drop, because each apnea or hypopnea is like your poke, is like your stimulus to the system, your CPAP drop. And so you can see how the system responds to each of these pokes to understand how it reacts and maybe calculate this arousal threshold, ventilatory muscle response, collapsibility, and so on. And so that's exactly what we've done. And so what we did is we used this method in people from the Ricazza study. And here you see Dr. Pecker from Turkey, who was kindly able to share the data with us. And we measured these physiologic traits in people with sleep apnea. And so here what you see are two real patients with fictitious names, Sven and Eric. And they both have AHI of 42. They are both Swedish, by the way. That is where the study was done. Um, and we wanted to see are their endotypes different, right? Are the traits different? So Sven and Eric both had pretty similar degree of collapsibility that we can rank on a scale of 0 to 100, 100 being totally normal airway, 0 being totally collapsed airway. And so they had both sort of a relatively moderate to mild collapsibility, but they had very different ventilatory control responsiveness. And they have very different arousal threshold, and they had very different muscle compensation. And so you can imagine that if different pathways lead to the same AHI, maybe the people will have different ways that they present with sleep apnea and might even respond differently to treatment. And so what we were interested in looking at is this arousal threshold, this uh, how ability of people to wake up from sleep from a respiratory stimulus during their respiratory event. And the reason why we're interested in this is because, we see this in clinic. You have some people who just like can't deal with CPAP, wake up easily, and other people can sleep through it, train going through the bedroom. And so, that person might be actually Eric because he has a very high arousal threshold. And so, what does the PSG look like for these individuals? And so if you look at the PSG for people with lower arousal threshold, they tend to have fairly frequent events. They're mostly hypopneas and they don't have deep desaturations. On the other hand, people with a high arousal threshold, that would be like the person like Eric, will have less frequent events, but they'll be longer and they'll be deeper. And so they might have a higher hypoxic burden. And so, to understand what these people might look like clinically, what we did is we went back to another study, a completed randomized clinical trial of people with sleep apnea who were treated with CPAP or sham to see if their neurocognition improved. It's called the Apple study. And what we're able to do is look at people with the first tertile and the third tertile of this arousal threshold. And so what we saw among those individuals, there was about 270 people in each category, was that those with a lower arousal threshold tended to be a little bit younger. They tended to be a little bit more frequently female. They definitely had lower sleep apnea severity in those with high arousal threshold, had less hypoxic burden. But if you measure their propensity to stay asleep, which we can do by looking at different spectra of EEG, their actual propensity to stay asleep was really not that different. And it's remarkable because, these folks with high arousal threshold had much more severe, much more hypoxic sleep apnea, but these guys had pretty much similarly disturbed sleep as these guys, despite having a much quote unquote milder disease. And the symptoms were actually quite different. So those with arousal threshold tended to present more so with insomnia. Their symptoms felt like they had more unrested daytime, and they had more fatigue during the day, almost twice as much. So there probably is a specific phenotype of people with this low arousal threshold and is trying to see what they might actually look like. And so let's talk a little bit about, how these traits might influence sleep apnea therapy outcomes. And so it turns out that Dr. Sands and others have actually done quite a bit of work looking at secondary data analyses to try to understand how these traits might influence success of PAP therapy. And the way they defined success was looking at, how much the AHI was reduced. And what they found is that if someone has a high arousal threshold, they don't wake up easily from sleep, if they have a low loop gain and they have moderate to mild collapsibility, then they tend to respond to oral appliances better, which kind of makes sense because oral appliances tend to improve the anatomy. And so if you don't have physiologic traits like high loop gain or lower the threshold that tend to perpetuate respiratory events, then you're going to succeed with therapy. And similarly, for those with hypoglossal nerve stimulation, if you have high loop gain or low arousal threshold, which are non-anatomical traits, and the hypoglossal nerve stimulator improves anatomy and muscle responsiveness, uh, those tend to not do well with hypoglossal nerve stimulation. We actually see this in our clinic for some of the folks that we implant with HNS. And similarly, these traits tend to help predict who might respond to just oxygen therapy with OSA. But the major gap in this work was that, you know, most people don't use non-PAP therapy. Most folks use PAP therapy. Well, this slide is a little bit old now. We have to update the slide and say, okay, probably maybe half of the individuals who use these prior therapies are going to be on some sort of a GLP-1 or pharmacotherapy that's uh, possibly to be approved within the next year for OSA. And so there's really not a lot of information on how do people with PAP respond to CPAP and whether these traits influence that. And so what we wanted to do is go back and say, okay, maybe these traits do influence how well CPAP works for people. And so we focused on this arousal threshold again, and it was a very basic thought that, if I awaken easily from a respiratory stimulus, I probably will awaken easily from a mask on my face or from changes in flow. Now, I might have a harder time tolerating CPAP therapy. And so what we did is we went back to this Ricazza study, which is the study of CPAP therapy in people with coronary artery disease, randomized to CPAP or usual care. And we examined longitudinal 2 years of CPAP use data for these individuals. And what we found is that a specific phenotype of individuals, a group that's characterized by both a low arousal threshold at baseline and very high or very low muscle compensation, tended to be very poor CPAP users. So these are the red lines here. The two lines represent raw data and also cross-validated prediction data. And those who didn't have those characteristics tended to have pretty good CPAP usage, relatively speaking, 4 hours. And so what it's showing us, and there's additional data to suggest that arousal threshold may be relevant in our prior analyses and others' analyses, that arousal threshold may influence long-term CPAP use. And in this case, the effect size was actually quite large. It's almost, hour and a half difference between these two groups. And so the next question we asked was, okay, well, do the traits influence CPAP efficacy? And efficacy, in this case, we define, well, okay, how well does CPAP treat OSA? We know that some people have high residual AHI and others may not have high residual AHI on CPAP therapy, even if we think that they might be rightly titrated. And so Erin, our former fellow and faculty at Einstein, had asked this question, and she wanted to understand maybe, do people with high loop gain, with high ventilatory instability, which may portend, residual treatment emergent central sleep apnea, or maybe having a hard time of the PEP adjusting to the upper airway fluctuations, maybe they have a harder time getting their sleep apnea controlled. So what she did is she looked at highest quartile of loop gain compared to the lowest three quartiles to see if they predicted residual AHI down the road within 2 to 3 months. And so she looked at this Apples cohort, which had about 500 individuals. And so when you look at just the difference between these two quartiles of loop gain, the highest quartile had about 3 times as likely chance of having this high residual AHI greater than 10. Say, okay, well, maybe if you adjust it for AHI, if you adjust it for age, there is some reduction in the magnitude of effect, but the effect persists. And so we adjusted for age, sex, for BMI, And then finally, for this metric of upper airway collapsibility, so we know there was not upper airway collapsibility. No, it was not an anatomical problem. And finally, we adjusted it for central sleep apnea in this cohort, and the effect size stays about the same. And we said, okay, well, we've seen a lot of data out there that, one-off, maybe this is just a one-off. So then we went back to Ricadza and did the same analysis. And what we saw that in those individuals, the effect size was even larger. So it's about, and that persisted regardless of adjusting for all these factors, including central sleep apnea at baseline. And so, if you have high loop gain in the highest quartile, you're about 2 to 3 times more likely to have residual AHI at 2 to 3 months. And so the last question that we asked is, so okay, maybe people can't adhere to CPAP as much, or maybe they may not succeed with PAP as much if they have high loop gain, but what about the things that we really care about? What about like the downstream outcomes? And so Chris Schmickel from San Diego got a hold of data from the Heartbeat trial, which was a trial that was published back in early 2000s comparing oxygen to CPAP in terms of outcomes in hypertension, and uh, and also oxygen, CPAP, and healthy lifestyle intervention, right? And so what he did is he compared healthy lifestyle intervention to CPAP as a function of loop gain, right? So the concept was that maybe this ventilator instability is an autonomic thing, and maybe those people with high or low loop gain respond differently to CPAP. And lo and behold, uh, he did show that that's the case. So actually, the higher the loop gain, and your patient at the outset, the more likely they are to respond to CPAP therapy in terms of reduction in blood pressure. And so we had connected with Clete Kushida at one of the meetings, and he is the PI on the Apple study, which is the largest randomized clinical trial of CPAP therapy in neurocognition, where people, about 500 in each arm, were randomized to CPAP or sham CPAP. And that original trial was negative. But when they did sub-analyses, they saw that, gosh, there may have been a transient mild improvement in executive and frontal lobe function. And this is actually important because executive function is one of those uh, parts of our neurological activity in the system is that is required for adequate planning, decision making, and execution of what we decide to do. And so it's like a really important concept in neurocognition. And so what we wanted to see is that, well, gosh, if people have a hard time adhering to CPAP because of arousability, and gosh, an arousability, I imagine, would be related to neurocognition. So does it really matter whether people respond to CPAP therapy or not? So what we did is we measured arousal threshold and other traits in this cohort to see whether there was an impact on CPAP treatment. And so we first looked at this metric of executive function called sustained working memory test. And what we found is that depending on what the person's arousal threshold was at baseline, so did they have a low or high arousal threshold, their CPAP response was very different. And so what you see in this chart on the y-axis is a standardized score of this executive function metric, sustained working memory test. On the x-axis is the standardized uh, arousal threshold. So 0 here means that it's an average arousal threshold. 1 means it's one standard deviation above average, and 2 is very high. -1 is moderately low, and 2 is very low, right? And so what you see is that if you have been assigned to CPAP versus sham, the response to CPAP with increasing arousal threshold starts to occur somewhere just above the average. And so if you actually look at people with high arousal threshold, they're the ones who are benefiting from CPAP therapy in terms of neurocognition. You say, I was like, oh, I don't know. What does this mean, Andrey? Uh, I don't know what these numbers mean, but luckily, folks who developed this test that calibrated it with other stimulants and other things, and what we see is that the effect of CPAP in this case is kind of like drinking a small cup of coffee, 75 milligrams of caffeine. Well, so that could be the difference between your ability to succeed with a PowerPoint presentation and sleep rounds or not. Um, and so we thought maybe, okay, maybe this was a one-off. And so we went back and looked at another metric of executive function in this study called paced auditory serial addition test. And lo and behold, we saw the same sort of interaction. And so the effect size for this test, which is asking people to remember certain sets of words with some tasks in between, uh, was about 50% of the difference that we see between healthy controls and people with severe sleep apnea. So effect sizes seem to be consistent, and all of these are adjusted for baseline sleep apnea severity. And the nice thing about a randomized clinical trial is that people are randomized. And so what you're seeing is the actual effect between the interventions, a function of arousal threshold. And so to summarize the work that we've done so far is, and what I've shared with you, is that these non-anatomical physiologic traits may actually impact how effective CPAP can be. And so for arousal threshold, we know that uh, adherence, we know that arousal threshold and muscle compensation, and there's some data from other authors that maybe loop gain may be relevant. We know that loop gain may be relevant for efficacy and blood pressure, and then also for neurocognition. The problem with these analyses, which they're fun and exciting, is that they're retrospective, and so you know there's no way that we can account for all the key confounders in these analyses, even in those randomized secondary analyses of the trials. And really, there's no targeted modification of these traits. So, if something is truly causative or truly is an effect modifier, if we change it, we should be able to see it change with treating it, and none of that stuff has been done. And it's not really clear whether these traits are biomarkers or they're mechanisms by which CPAP may work. And all these sort of questions came up during the workshop that ATS held in the last couple of years to try to understand, okay, well, now we have these promising endotypes. How can we bring them to bear on clinical practice? And so there's a lot of gaps, as you can see. And so we are actually now trying to answer some of these gaps and fill some of these gaps through a clinical trial where we are looking to change arousability in people with sleep apnea and see if it affects the outcomes of CPAP therapy and how. And so this is a randomized clinical trial that was um, funded by the NIH. And the question we're trying to answer is this arousal threshold a mechanistic determinant of somebody responding to CPAP therapy? And so our aims are to understand how it might affect adherence if we change the arousal threshold. What are some of the mechanisms by which changing arousal threshold can lead to changes in neurocognitive response? And we're going to measure executive function and other things. And then try to explore the link between this arousability and cardiovascular function. And so what we're doing is, and we're poised and ready to go. And so like Naya, Mohammed, and Yuri and I and other folks have been working really hard on getting this trial up and running. And so we're poised to start recruiting in the next couple of weeks. We're looking to recruit adults with newly diagnosed sleep apnea of AHI 4% greater than 10 per hour that haven't had CPAP in the past and medically stable. And then we're going to have them do a run-in. We're going to do a PSG to measure their arousal threshold. And then we're going to randomize them to either eszopiclone, which is a sedative hypnotic, or placebo. Afterwards, we're going to measure another PSG to get a sense of what happens to their arousal threshold on this new treatment. We're going to titrate them on CPAP therapy, and then we'll follow them for 3 months. And we're going to measure neurocognitive function. We're going to do blood tests to assess biomarkers of neurocognitive decline, biomarkers of endothelial function, biomarkers of autonomic and HPA axis, measure their symptoms, and then assess their sleep, adherence, and efficacy, daily and monthly cognition. So that's the objective of the study. And so if you have patients who might be newly diagnosed with sleep apnea who are amenable to CPAP therapy, please send them our way. We would love to include them in the study. And so the concept that we're testing is whether this arousal threshold is a modifiable biomarker, and does it determine CPAP adherence, cognition, and cardiovascular function? And we're actually looking to see how it happens. So we got to measure sleep duration and measure sleep depth. Check to see if the CPAP levels are the reason why that happens. CPAP tolerance or claustrophobia that may be changing with arousal threshold changes. And then for the cognitive and cardiovascular outcomes, we're going to see is it adherence? Is it how much OSA is alleviated? Right. So what we're going to do is we're actually going to measure how much people sleep on CPAP and understand, through their sleep duration, how much of their sleep is actually covered or uncovered with CPAP therapy and all these other potential mechanisms. All right. And so how might we do this? How might we use this? And so one way to do this, and this is what I would propose, we have probably started to accumulate enough data to create a prediction tool for CPAP success. And we know that success of this complicated therapy is multifactorial. It includes not just physiological data, it includes clinical characteristics, social and psychological features. So, we know that sleep literacy and partner support are super important for adherence. We know that decisional balance and self-efficacy are super important for ability to succeed with CPAP therapy. We now know that people with insomnia have a harder time with adherence and outcomes, and those with high hypoxic burden may actually benefit from CPAP more than those without it. And we have some additional data now that maybe these traits, these endotypes, might be relevant for success. And so build a predictive model using these modifiable factors, and we can stratify people into somebody with high or low likelihood of success. And if they are high likelihood of success up front, this is wonderful. Give them PAP and, c'est la vie. I hope you enjoy your new refreshing sleep. But if they have a low likelihood of success, that's when the risk determination and shared decision making come into place. And so that's where we can probably start tailoring PAP interventions, not just CPAP alone, but with potentially adjuncts. So if people have a predicted to have a hard time with adherence because they have ambivalence about treatment, or because they have insomnia, or because they have a low arousal threshold, we can target those with motivational enhancement, CBTI, and hypnotic use. Right? If they're predicted to have a high residual AHI, well, then because of either the positional severity that changes the high loop gain, those can be treated too. Now, if their sleep apnea sequelae are of uncertain significance, like they're not sleepy, they don't have hypoxic burden, or they have lower the threshold alone, we don't really know what to do with those individuals, and that's something that requires further study. And then if they have a very strong preference for non-PAP therapy, then we have additional treatments that we can offer them, like oral appliance, CNS, HNS stimulation, and upper airway muscle training, and medications. So that's the vision, and we are slowly working on gathering data to make this a reality. Um, and so I'll just go through a couple of take-home points for this section of the talk, is that these physiological traits do seem to be relevant for pathogenesis and therapy success. We have still yet to work out the appropriate cutoffs and levels at which we can make predictions that are valuable to understand who responds, who doesn't. But there's enough preliminary data to do that, and we're actually doing some work to understand how to get to those levels. And so I also wanted to share some other areas of research that we do in our lab. And so one of the questions we're trying to answer is, for those people who are using CPAP devices, we don't know if they're sleeping or not. They just wearing, there's plenty of people out there who wear the device to meet the adherence criteria. And so we're developing algorithms to determine sleep from just the breathing signals to improve what we get out of the CPAP device. So is my patient actually sleeping? Are they getting REM on this device or not? There's also some equipoise now about what is the first line treatment for sleep apnea. Is it a GLP agonist like tirzepatide, or is it CPAP? What should we be using? That's an unanswered question. And so, our Yale Sleep Center that's, led by Clara Yagi as the site PI and me as a co-I are participating in an application process for a patient-centered outcomes research proposal to study exactly that question. And some of the work that we do in collaboration with our colleagues from cardiovascular division, Allison Gaffey, is that we're finding that, gosh, sleep apnea and insomnia have some shared pathways in which they might influence cardiovascular disease. And so, do they portend a unique risk if they're together? And so, what we're finding is that actually some large data sets of over 1 million people at the VA is that COMISA and above and beyond sleep apnea and insomnia alone poses a higher risk for hypertension. And then the last thing that we're focusing on is some novel metrics of risk for cardiovascular disease. And this is something we sort of stumbled on, or is I stumbled on through some of the work we were doing in the space of sleep apnea heterogeneity. But it turns out that this area, unbeknownst to me, has already been studied, and there might be some signal here to suggest that might be other risk factors for cardiovascular disease other than sleep apnea in these individuals. And so I just wanted to take the next 5 minutes to talk through some of the data that we have gathered. And so what are PLMs? And so this is a video that shows you what they look like. I think most of us kind of inherently think that we know what they look like. We probably had them as hypnic jerks as we were falling asleep. But all these movements are typically associated with the following changes. So there's increased EG activity of the alpha beta frequency, so more arousability. The heart rate goes up, the blood pressure goes up with these events, as far as we know. And so it's plausible that they may actually influence cardiovascular disease. And in fact, our own Dr. Koo, back in 2011, had done an analysis in a Mr. Oz cohort to look at plausibility of this. And Mr. Oz cohort are older men that were being studied for osteoporosis and other things, but they also were evaluated for sleep and consequent cardiovascular events. And so what he found is that with increasing frequency of PLMS or PLMI greater than 30, there's actually a risk of higher rate of cardiovascular events, mostly driven by peripheral vascular disease and predominantly in those people who did not have prevalent hypertension. But nonetheless, this is one of the first studies that showed that PLMs might be a risk for cardiovascular disease. And so in our own work, when we were looking at trying to understand heterogeneity of sleep apnea, we did some clustering analyses to look at different metrics of sleep apnea. So, we sort of broke down people's metrics into heart rate changes, the apneas, hypopneas, are they in REM or non-REM? Are they aroused? Are they associated with desaturation or not, et cetera? So we did a cluster analysis of about 1,200 veterans who were evaluated for sleep apnea at the VA, and we found that there were these different clusters of sleep apnea that we characterized as, mild, non-REM poor sleep, REM hypoxia, people with very high frequency events that had a lot of hypoxia, minimal hypoxia, a lot of arousal, et cetera. And what we found is that they had different risks of cardiovascular disease. And so, these boxes highlighted in red are the phenotypes that had higher risk disease. And so, it wasn't surprising that people with frequent events and severe hypoxia and people with frequent events with hypoxia and arousals had higher risk of cardiovascular disease. But what we were shocked to see is that people with very mild sleep apnea and a lot of PLM, so the average PLM in this group was about 50 per hour, had higher risk of cardiovascular disease. And so we try to understand, is this interaction between sleep apnea and PLMs, the PLMs alone? What's the role of each in this category? And when we went back to look at this and published this paper in Journal of American Heart Association, we saw that actually it was not the sleep apnea. It was really just the PLMs. And what you see here are some survival probability curves, Kaplan-Meier curves, that show that if your PLMI is greater than 30, your risk of heart disease is much, much higher, or death in this case. And this is Pat Shrivali, who was our former fellow, who was very productive, actually published 2 papers during his fellowship. The second one being doing a meta-analysis of PLMI risk and risk of hypertension. And so the, the story is starting to thicken a little bit, that we have more and more support that these PLMs, regardless of sleep apnea, may be a risk factor for cardiovascular disease. And so another colleague of mine was a PhD nursing student who was interested in sleep research, and we conducted this similar cluster analysis to see, gosh, these clusters predict risk of diabetes, incident diabetes. And what we found is that, lo and behold, gosh, it's not just cardiovascular disease, it's also the PLMs that affect the risk of diabetes. And so Priscilla Ding, who is now a faculty at Purdue, did this analysis, and then she went back and said, "Gosh, okay, is this real? Is there another data set that I can study this in?" And so she went back and looked at NHANES, and this is cross-sectional associations. But what you see is that self-reported sleep-related limb movements, like leg jerks, were associated with increasing risk of incident diabetes and H1C levels. A1C levels. And so, slowly we're starting to understand that actually PLMs may be another risk factor of CVD, things that we generally tend to ignore on our PSGs, and may need to be addressed. And this is regardless of restless leg syndrome. And so this is a ripe area for investigation that I think we need to address in the next few years. And so just to summarize this part of the work is that, there's some mechanistic plausibility that cardiometabolic risk is increased with PLMS. We've had some data that the PLM frequency may be associated with hypertension, cardiovascular disease, or death, and diabetes. And so what we really need are some prospective mechanistic study to understand whether this is true and why that is, and maybe we can intervene. And so I'll stop here and share with you the photos of my best and biggest collaborators and sponsors and mentors. This is my mom and my son here. My mom is a physician pediatrician, has always been a role model. This is my daughter, who is all things athletic and surfer and a runner, and always tells me that I shouldn't quit. This is my family, including my wife Laura, and that's my dog, who tells me that nothing in life is indestructible, permanent. So I'll stop here and be happy to take any questions.
Uh, Thank you, Andre. That was an amazing talk. It was informative and thoughtful as always, so thank you. And it looks like we have a question from Dr. Karen Johnson. She asked, do you think we have enough trait data off home sleep studies compared to like PSGs to help make these decisions, or do you think an in-lab would be needed?
Wonderful question, lovely question. And so two-part answer. Part one is that I don't think even with PSG data, we have enough information to make clinical decisions. That's the work that still has to be done. I think we're all excited about these things being potentially useful, but I think we really need to do the prospective randomized clinical trial studies that we're doing now to see if they really are useful. And then part B, and so I have to be very, even though I'm a proponent of this, potentially being useful thing, like I'm very cautious about using it in the clinic yet, because it's not, may not be quite ready. I mean, for some individual patients you may, but in terms of the measurement, yes. So actually, there are several groups working on getting these traits out of HSAT data, so effort and flow and oximetry. And there's actually groups looking and getting these traits just out of oximetry data. So this will become available very, very soon. And so uh, yeah, so there's not to advertise, but there's a company called Knox that they actually are currently publishing data that shows that they can extract these things from the data from home sleep apnea tests. So that's whether that data is validated for clinical outcomes yet, we don't know. And that's the kind of analyses we need to do with the clinical trials. I see Brendan had posted something in the chat. Thank you, Brendan. Right, and that's Jeremy's paper. Yeah, I should have mentioned that too. So Jeremy Orr had published in the Blue Journal a way to get loop gain out of a home sleep apnea test. And so that paper is in the chat, so folks are welcome to peruse and bug Brendan to give him the code. Um,
You mentioned the prediction tool for CPAP adherence. Do you
mhm,
have any like idea of what percentage of using that tool would indicate people are like a good candidate for CPAP versus not and needing more detailed
mhm,
discussions?
mhm. Right. So I don't. We are actually actively working on developing that prediction tool. So, you'll have there'd be we're using like a biopsychosocial model of adherence, which is a complex behavior that influenced by all those things, to try to identify what are some of the key predictors and at what levels these predictors might influence adherence. And so that model is being built currently using another study that we just completed called NICEPAP study, which is a prospective cohort of people with sleep apnea followed for 6 months. And so I don't have an answer to that yet, but the idea is to generate essentially a calculator to give you a probability of CPAP success using those factors.
Well, we'll look forward to that.
Yeah.
If anybody has questions, you can unmute yourself or put them in the chat. Um, you were talking, the last section of your talk was on the periodic limb movements of sleep and increased risk of diabetes, cardiovascular risk, and how we often can like not really focus on the PLM
Mhm.
index. Do you think providers should be starting to like, if they start CPAP, we'll do a titration study, and then we'll often see continued periodic limb movements. And then we say that might get better over time. Should we be potentially repeating sleep studies to see if
Mhm.
these indexes are improving?
Yeah, so I have started doing that based on the data that we've seen, and it's not terribly common, but I've seen a bunch of patients who are still feeling miserable, have poor glucose control and hypertension, and like their sleep apnea is well controlled, but they have a PLMI in the 50s and 60s, and so they don't have RLS, but it's pretty hard to ignore that all these limb movements leading to, sometimes leading to arousals are just not worth worrying about. And in fact, actually, what I will add to that is that we may not need to wait for the PAP to treat the sleep apnea. Because, one of the things to remember is that we actually don't score PLMs according to ASM rules if they're associated with a respiratory event. So if somebody has severe sleep apnea, you're not going to have PLMs around those events. Even though the leg movements are there, they're not going to be scored. And so if anything, it's to underestimate. And there's also data from the Apple study, because they did score PLMs, looking at
Mommy, do you
whether
want to play
PLM index
with
improves with
No,
CPAP
thanks.
therapy.
Leave them there,
Uh,
honey.
and the answer to that is that it doesn't. And so CPAP or not, PLMs tended to persist. And so for those people who have, like hard to control blood pressure or poorly controlled sugar or still have some residual symptoms, actually start paying attention to the PLMs uh, regardless. And I've been actually checking iron levels for those individuals. Um, all right, so I see Yvonne has a question. Do you routinely use some POC tools for estimating traits and applying these to my therapy choices? So thank you, Yvonne. Yes, I do in some cases. So arousal threshold is pretty easy to do. And if I am thinking about potentially using a sedative hypnotic or trying to understand why someone might have a low easy arousability, I will use that tool. And that's one where you can look at the number of hypopneas, the O2 nadir, and the severity to help you determine if someone has a low arousal threshold. The loop gain tool is a little bit harder to use. Um, and let's see, I see notes, putting some stuff in there. So the looping tune is a little bit harder to use because you need to know MATLAB. But what I typically do is I look at, is there disease in REM or non-REM? So if there's no disease in REM and all diseases in non-REM sleep, and the oximetry pattern is sort of the zipper pattern, which is almost metronomic, suggesting sort of disease centrality, that to me sort of indicates high loop gain. But if anyone is interested in actually getting these traits for their patients, let me know. We can pull it out of their routine PSG for you. Okay, and then I see Dan McNally looking at a cartoon of the young woman wearing her CPAP, looking very unhappy. I'm reminded of a concern that I have that implicit bias about CPAP from both providers and researchers may affect how patients respond. As a researcher, as a provider, how do you take steps to avoid that bias? Oh, that's a great question. And so that cartoon actually it is not meant to say that people can't tolerate CPAP, but that this person had both sleep apnea and insomnia. And so that's the best that I could instruct ChatGPT to do with making that picture. But that's a great point. I think for me personally, I still refer to CPAP as the primary and the most efficacious treatment. Um, and so I try not to discourage people from using that treatment, and I try to lay things out for people um, that are in front of me and say, okay, these are treatment options. This is how often this works. May have trouble with adherence. This is how when this works, but some people may have trouble with their jaw. HNS is an option, but you have to try other things, and this is a GLP. And so I think that's a really important point, is to not to bias people against CPAP. But I'll tell you, I've had plenty of people who were on HNS who have sort of come back to use CPAP therapy
Well, Andre,
because
the
that really did a
reason to
good
call
treatment.
it implicit bias is that the problem is that we don't realize we have it. So
Mm.
in your spare time from all the prolific research you're doing, you might want to head in the direction of figuring out a way to detect that kind of implicit
Uh-huh.
implicit bias.
So are you Okay, so it sounds like you think I have it, which is okay. It's good.
No, to detect it and measure it
Yeah,
and do something
yeah,
about it.
yeah. That's
And other
interesting. I
people.
mean, that's actually a good idea.
Oh,
Maybe
you're
we
a
can do something with Vivian Asari and try to measure that, not just CPAP, but all the other things, and CPAP being part of it. That's a great idea. Let's see.
And then
Another
there's a
Brendan notes.
question. Yeah,
Yeah, go
sorry,
ahead.
go ahead.
Go ahead, Sri. Parvati.
That's okay. There's a question from Dr. Men about any thoughts about K-PAP based on traits.
Uh-huh. Um, I I don't know, but my guess would be that APAP might be actually helpful with treatment emergent central sleep apnea. And so, just because if you have more pressure than you need during inspiration, you might get more ventilation than you need. And so you
Mhm.
might be closer to the apneic threshold. And so you might have more central disease. And so with KPAP, I imagine the TCSA might be better. I don't know if that's true or not, but I think mechanistically that would make sense. And I'm pretty excited to see what actually happens with KPAP in the real world. Um,
Have you used K-PAP yet on anybody?
no, no, not yet. Uh-uh.
Okay, me neither. It looks like there's another question. Do patients with views that CPAP work from friends, family who may be on it do better and have better compliance?
Oh yeah, for sure. I mean that's been actually studied, and that's part of the self-efficacy measurement tools called SEMSA that Terry Weaver developed. And one of those scales has to do with your outcome expectancy. And people who have friends and family who have succeeded and benefited from CPAP tend to try harder, persist longer,
Mhm.
and seems like tends to succeed more with CPAP therapy. So social support is a huge part of it.
For sure. I think we're a little past 3 o'clock, so we can probably wrap up here. Thank you so
Okay.
much, Andre, for like staying and answering all our questions.
Oh,
And
thanks for listening.
and we'll see everybody next time. Thank you, Andre.
Nice to see you, Dan. Thank you.